Good morning, everybody. We're just letting people in through the waiting room. Welcome to this virtual information session on Nemaline Myopathy. Just going to let a few more people come through. I had a horrible moment where we lost people on the way from the waiting room, but they appear to have appeared now. I wondered if that was the global internet outage, but we seem to be okay. So I'll just wait a couple more seconds. We've got a couple more joiners coming through. Thank you very much for being with us.
Rob, can you see the slide now?
I can see the slide. Perfect.
Brilliant.
Thanks, Kate. I'll just move some winners around. So yeah, I'll start us off. Brilliant. So yeah, hello everybody, and welcome to this morning's virtual information seminar on Nemaline myopathy, which will focus on both adults and children. I'm Rob Burley. I'm Muscular Dystrophy UK's Director of Care, Campaigns and Support. We've got a packed agenda this morning with a great array of speakers, so we're going to split the session into two parts, beginning with a discussion on research and a chance to ask any questions you might have on that topic. And then we'll move on to discuss living with Nemaline myopathy, where we'll have a general discussion and focus on answering some questions that we've had in advance, as well as covering any that come from you as the session progresses. We'll be using the Q&A function. So at the bottom of the screen, you should be able to see a Q&A button. So if you could write your questions in, I'll compare the questions and relay them back to the panel. That just helps us manage the technology a bit more easily. Any questions we don't manage to cover or we don't know the answers to in the session, we'll seek to answer via the website afterwards. Before we begin, a note that our helpline is available to anyone affected by muscle wasting and weakening conditions, and so do please contact us if you have any questions or are in need of support. We can help with information, and we can either support you directly or point you to where you can get support with things like advocacy, accessing financial support, or just information about your condition. The number and email address are on the screen, or should be on the screen at some point, but the numbers are 0800 652 6352, or you can email info@musculardystrophyuk.org. We'd very much like to thank our sponsor today, PTC Therapeutics. PTC Therapeutics have sponsored this virtual seminar, but have no control or influence over the event and did not have any role in planning the content or assembling the panel. A final reminder that we're recording the session and it will be made available on the MDUK website over the next few days. And I said that was a final reminder, but I'm going to plug again the fact that you can use the Q&A function as well. So to do please interact with the session as we progress. So it gives me pleasure to first of all introduce my colleague, Dr. Kate Adcock, our Director of Research and Innovation, who will be chairing the first part of today's session, and we'll introduce our research speaker. So Kate, over to you.
Fantastic. Thank you very much. So good morning, everyone. It's wonderful to be here today to talk about Nemaline myopathy. I'm really delighted to introduce you all to Dr. Gemma Fisher, who's a clinician working at the Oxford Neuromuscular Centre, the MDUK Oxford Neuromuscular Centre, no less. She is one of the key people involved in a study that we have just we funded and is just starting up on Nemaline myopathy, and she's going to tell us a lot more about that in a moment. So she's a paediatric neurologist, and she's developing in her neuromuscular expertise, and through the study that she's going to talk about today, she's also working towards a PhD. So incredibly busy lady. Thank you so much for joining us, Gemma, and I'm going to hand over to you. Do you want to start sharing your screen?
All right, here we go. Is that working for everyone?
That's perfect. Yeah.
Brilliant. Thank you for the kind introduction, Kate. So I'm a trainee neurologist, not quite a consultant, and I work for Professor Survey, who I think probably needs no introduction, but sends his apologies for not being able to make it today. He's the chief investigator for the natural history study, which I'm going to come to, but I'm briefly going to explain what Nemaline myopathy is. Now, I know this audience is an audience that clearly knows what Nemaline myopathy is, but I'm just going to explain a couple of key points that will be relevant to the research that I'm going to come on to talk about. So I'll talk about what's currently out there in terms of natural history data, some of the treatment options now and where things are heading in the future, some of the research needs, and that should lead into the natural history study that we have planned. So really briefly, Nemaline myopathy is a rare neuromuscular condition. They were originally identified by the presence of Nemaline rods on biopsy with an associated clinical picture, but things are changing. It's more usually a genetic and clinical diagnosis. Really variable in terms of age of onset and severity. So there's a slight caveat to all of these sentences because not everybody is affected in the same way. But generally, it involves skeletal muscle weakness, breathing difficulties and swallowing difficulties, and generally things progress slowly over time, but not always. This is a very scientific diagram, but I just thought it would be useful to kind of show where the genes are that are involved. So there's at least 12 genes in which abnormalities can lead to Nemaline myopathy, and they all affect the muscle in different ways. So in the top left corner, there's a muscle, and then within that you've got muscle fibers all grouped together, and then within that you've got the contractile unit of muscle called a sarcomere, which is then shown in this diagram with the purple and the yellow lines. And if you can imagine, it's sort of like sliding doors that go together, or if you can see my fingers going in and out to contract and release. And the genes encoding proteins involved in Nemaline myopathy are kind of dotted throughout this structure, but most commonly associated with the purple fingers, or the thin filament. And the most common genes involved are called Nebulin and ACTA1, and that accounts for most cases, but not all. And then in terms of how abnormalities in those genes cause problems with the contraction of the muscle, the presence of the Nemaline body might contribute a little bit, but also there are issues with calcium sensitivity. So you need calcium to initiate your muscle contraction. So it's a bit like starting the car doesn't quite work as well. And then there's impaired interactions between the purple and the yellow sort of sliding mechanism. So it's like the sliding door, the rails or the door might not slide along properly. And then there's also disturbances in protein turnover. So if you break the rail or break the door, you might not be able to replace it very easily. So that's kind of a rough scientific background. And then what I also thought would be useful was to cover sort of what natural history data is currently available. And again, I appreciate this is a very big scientific looking table. This is not an exhaustive list. This is a list of sort of the biggest numbers of cases, but there really are about 13 papers, so there's not a lot more than this. But the papers that have been produced looking at the natural history of Nemaline myopathy are really thorough, really detailed, and definitely help us to understand the condition. What's most useful to note about this table is that most of the studies are retrospective. So that means that people have looked at the notes of patients with Nemaline myopathy and looked backwards to see how things have changed for that patient throughout their life. There are a couple that are highlighted in green that are prospective. So people have looked at patients at one point in time and then gone on to assess them again in the future. The one at the top has 16 patients with TNNT1, which is one of the less common genetic causes. And the one in really big green box is one that covers all the mutations, and I think has been really useful for planning our natural history study. So they looked at 57 patients with Nemaline myopathy and saw them at one family conference, and then tried to see them again at the same family conference 7 years later. So they have longitudinal data in 16 patients that they managed to get on those 2 occasions. And that's been really useful, the information from that. From that study by Ambergi and team, this is a graph from their paper, and I really like this bottom diagram D, where it shows what life is like, I think, for people with Nemaline myopathy in one very brief view. So it shows that at least 51% of people need feeding support in the form of a tube, where 49% of people manage to feed orally. It shows that 32% need invasive ventilation, so that's a breathing tube and breathing support. 28% of people need non-invasive ventilation, so that's a mask and breathing support via a mask, and 40% don't need any. And then 51% of patients with Nemaline myopathy are able to walk, where the others are needing a wheelchair of various degrees of support. So the current data, as I've kind of discussed, is mostly retrospective, and there's not a lot of longitudinal data following patients up over time. I'm going to ask you to hold that thought as I change tack a little bit, but this will be relevant for what we're going to discuss. So then jumping to the treatment options, the current treatment options are really supportive for Nemaline myopathy, and the supportive management is key. It has a massive impact on patients' lives, but it doesn't change the disease course that much, and that's a real need. So there are therapies in development in several different ways of targeting the abnormalities associated with Nemaline myopathy. And this paper, I'm sorry, it's a plug, it's a paper written by our team, but it's the team that are developing the natural history study. And this was really useful for us to understand the role of the natural history study and where things are heading. So there are actually lots of treatment options, not particularly available at the moment, but in development. So again, these are very medical terms in this slide. So the treatment modalities include gene therapy, so that involves replacing the abnormal gene or maybe a smaller version of the abnormal gene. Multi-exon skipping, so that's like ignoring certain chunks of a gene. Antisense oligonucleotides can skip a small amount of a gene to skip over the abnormal part to read a hopefully more functional protein. Exon exchange involves exchanging bits of genetic material. Pyrologous gene upregulation involves looking at a gene that has a similar function and seeing if you can make that gene produce more protein, if it then kind of can take the place of the abnormal protein. The myostatin pathway is involved in regulation of muscle growth. And then there are fast troponin activators and calcium sensitizers that acts on how sensitive your muscle is to calcium and initiating the muscle contraction. Pyridostigmine is a drug that works on the muscle junction, and then there are sort of dietary supplements that people have looked at. So that's, yeah, sorry, very scientific and genetic based, but a bit of a run through. And this table summarizes those treatment options and where things are up to in the preclinical data. It's a really busy table. It's got the genes, the causative genes along the top, and those treatment modalities along the left. And the key message is anything that's red is not possible, but all the other options are theoretically possible. And I think this is actually quite a lot. I think it's really promising and great to have so many options available. The orange, yellow, and green coloured bits of the table show where the data has been tried in mice, fish, or in human muscle in a test tube, and some of the vitamins have been tried in human people in real life, but most of it is in the lab kind of stages of development. So we think that some of these treatments will be available in the next 5 to 10 years, but in order to see if those treatments work, we need to know have a really good idea about the natural history of Nemaline myopathy, and there's not quite the natural history there to support a clinical trial, which feeds on to the natural history study that we're going to do in the UK. So the basis to the natural history study is a European Neuromuscular Centre workshop where 18 doctors and scientists got together with 2 patient advocates from 11 countries. And for 3 days, they sat in a room and they planned a natural history study. And they were in the Netherlands, hence the picture of beautiful boats and water. And then this was the paper they produced, this meeting. Professor Survey was one of the leaders of this meeting, hence being one of the perfect people to take the natural history study forward. And here's a picture of Professor Survey and the MD UK information advertising the natural history study. So the natural history study in the UK is going to be a multi-centre longitudinal prospective study. So that means we're going to see patients and follow them up over time into the future, and we're going to follow them up for 3 years. we hope to recruit 45 patients in the UK, adults and children. And MD UK have very kindly funded this study and have been instrumental to getting this off the ground. The centres involved are Newcastle, the Evelina in London, Great Ormond Street Hospital in London, and Oxford are the coordinating centre. So the teams, there's lots of people are the key people involved in those teams at each centre. And also really important to mention that patients and families with Nemaline myopathy and similar neuromuscular conditions have had a really key role in planning this as well, and have had really valuable contributions to the study design. So a really multidisciplinary collaborative team. And here is the team. We had a recent kick-off meeting where we discussed all the nuances of the planned study. And the aim of the natural history study is to understand the natural history. So going into that in a bit more detail is, how does the gene correlate with the clinical picture? How quickly does the disease progress? And are there factors that can predict progression that help us plan and look after people with Nemaline myopathy? And then the other aim is clinical trial readiness. So we need to know which scales are going to be useful, like can people tolerate doing those tests and assessments, often with physiotherapists? Are they going to show that there's a change? And if then people test a drug in the future, are they going to be a useful measure to base those treatment decisions on in clinical trials? We need to know how many patients are going to be useful for numbers in future clinical trials, especially because it's a rare condition. We need to see if some of the scales that we're testing match other scales. So maybe like a questionnaire, does that fit with a physiotherapy assessment? And are the assessments acceptable for patients to do? And then within that, we aim to have a database of patients who want to be included in that database to optimize and streamline recruitment to clinical trials when they're available. And all of these things will also contribute to the design of clinical trials, making sure that they are the most appropriate for patients and feasible and acceptable. So this is our plan. So we're hoping to start recruitment September, October. So coming up soon. And as I said, it's 3 years of follow-up. So we're going to try and minimize the burden on everyone by seeing patients at their hospital visit, at their standard clinical appointment. And then most patients have an annual appointment at least, if not more frequent. And so we'll see patients at their hospital appointments over 3 years. And we also would like to see the younger patients every 6 months, because we know that with growth and development associated with normal childhood, things might change more quickly. And to try and, again, minimize the burden on people, we have a physiotherapist who's going to travel and see patients in their homes, and try and minimize the burden in that way. There might be, if they have a hospital appointment, we may do it then. It just depends whatever is easiest for the patient involved. And at those visits, it will require their usual medical assessment. There's quite a lot of overlap with what would be done as part of standard of care. And they'll have some physiotherapy motor assessments, some breathing assessments, some swallowing assessments in the form of questionnaires, some other questionnaires. And then there are some more exploratory studies looking at outcome measures that we think could be really useful for this population and to be honest, many other groups of patients in the future. So there are wearable devices that you wear on your ankles that can be done with participants in their homes, not needing to come to hospital. It gives a real world view of what's happening rather than that brief moment in the hospital environment where they might have had a bad sleep the night before, a difficult journey to the hospital. It's a scary place for some people. There's lots of reasons why the hospital environment might not be the best for some things. And Great Ormond Street are looking at digital plasmography, which is a way of assessing breathing without having to, patients aren't required to do any particular controlled breathing into tubes. It stickers on their chest and a machine records the chest wall movements. So a lot less invasive and really useful, particularly for younger patients who it's just not possible to coordinate their breathing. And then when patients have bloods taken as part of their annual appointment, we would like to take some extra blood to store it to look at proteomic analysis, which will help us hopefully understand a bit more about the protein interactions in Nemaline myopathy. So I've alluded to it a bit, but we're trying to minimize participant burden wherever possible by trying to reduce those visits to hospital, the remote visits. The visit durations are going to be matched to age and ability. So younger patients will have shorter visits, and less able patients will have less tasks to do. So hopefully it's less tiring. And then the other element of this is, Nemaline we all know that Nemaline myopathy is a rare condition. So trying to maximize patient numbers. So we have been collaborating with international teams to try and combine natural history studies and combine the data. So we've been liaising a lot with the team in Stanford in the US, who are starting a similar natural history study and plan to include 50 patients. And we have aligned studies to try and maximize the impact of everybody's work. And then there are other centres around the world that are looking to join. So that includes Sweden, the Netherlands, Germany, Australia, South Africa, Brazil, and Canada. So really exciting, really collaborative efforts. And our aim is the bigger picture is the Nemaline myopathy natural history study fits into this orange bar here. All the work that's happened before it has been incredibly useful. We're already expanding it to other countries to maximize the impact. And then we hope that this will contribute to clinical trials and get some approved treatments available to hopefully change the disease course. This is some of the acknowledgements of the team involved in planning this, so it's not an exhaustive list, but yeah, that's the summary of where things are up to. So thank you for listening, and then I guess questions.
Wonderful. Thank you so much, Gemma. That's really, really interesting and very useful to see the plans for the study. I have got some questions, and do encourage people who are joining us online to use the Q&A function to ask questions as well. I don't think I see any as yet, but I do have some questions already for you, Gemma. You mentioned that there are teams based at Oxford, at the Evelina in London, at Gosh in London, and at Newcastle. If people don't normally go to those hospitals, what should they do? And if they want, even if they do go to those hospitals, how do they get involved in the study?
So brilliant that it's not restricted to those hospitals at all. We welcome participants from throughout the country, and we'll try and allocate the easiest hospital for them to be seen at, with some of the budget to cover some of their expenses. From an ethics perspective, we have to be careful about how we contact people, but if you contact MD UK, then and they pass on the details to us, brilliant. We would be really excited to include as many people as we possibly can, and to try and make it as easy for those people to join as possible.
Wonderful, thank you. And you mentioned at the beginning that actually Nemaline myopathy is caused by changes in all sorts of different genes. So, and you said that there's ACTA1 and Nemaline are kind of the most common. Are you only looking at people with changes in those genes, or are you open to people with any kind of genetic cause?
Yeah, excellent question. Thank you. So we're looking at all of the genes involved, the 12 key ones, and if there are some ambiguous cases, then we'll discuss it as a team. But the reason for that is that when with that table of treatment modalities, we don't know which treatments are going to be available first, and which genes are going to be included in those treatment options. So we felt that if we didn't include some of the genes, even if we only have 1 or 2 patients with that genetic abnormality, then it's denying that patient group a treatment option in the future. So although there are arguments in some ways for focusing on the more common genes, we felt that it was most inclusive and maximizes the impact of the study to include everyone.
Fantastic. And you said, obviously age of onset is different. You're looking at children and adults? Are there any age limits with that?
No age limit at all. The only exclusion criteria is if somebody has another condition that could affect the results because of the other condition and not due to Nemaline myopathy.
Okay, that's clear. Thank you. There was another. Oh, going back to the gene question, do people already have to know which gene that they have, so that they would need to have a genetic diagnosis?
So yes, but mostly. In most cases, we expect they will do, but I think we may talk about this potentially later on as well. But there's the clinical aspect, the genetic aspect, and then the biopsy findings. But biopsies are becoming far less frequently done because you can manage with a genetic diagnosis and a clinical diagnosis. But there may be reasons why some patients might have one and not the other. So it's not a definite no. If it'd be a discussion.
Enough. Thank you. And actually, that you're mentioning about biopsies is really useful, because you talked about the burden of the study insofar as you're going to try and minimize additional hospital visits, and for younger participants there'll be home visits for sort of that interim part of the study. Will you be taking any biopsies, or is it just blood and movement, breathing, and those sorts of tests that people will be doing?
No biopsies. So none of the tests are invasive apart from their routine blood tests that we would want to take extra blood for. That's the most invasive part, but we're not going to do a blood test separately to what they would ordinarily have. The biopsy question is, I think it could provide useful information, but that is so invasive that ethically, having an anaesthetic to have a biopsy, and it just wasn't felt to be feasible.
Yeah, no, okay. And I think that's probably, for anyone who has had a muscle biopsy, I think that would be a good news, because they're not pleasant, they're not nice, and so I can understand that would be preferable for patients. So for participants, that's wonderful. You mentioned again about the clinical trials, and we just don't know which direction the studies are going to go in to take us to the next clinical trial. Have I understood that correctly?
Yeah, some of the treatment options are drugs that are available for other conditions. So in some ways you could argue that they would be quite easy to move into a clinical trial, and then historically clinical trials have always been done in adults and then filtered down to pediatrics, but things are changing a bit with that. So in some ways those drugs would be easy to test, but the unfortunate truth of pharmaceutical companies and money making is that those drugs are already making a lot of money for common conditions such as heart failure, and trying to entice them to test in a rare disease isn't always easy, but it's definitely possible. And those drugs might not have a massive impact on the course of the disease either, but they might make life a bit easier in certain ways. Where some of the other treatment options could really be life-changing. So like a gene therapy given quite early might have drastic effects. And then that might get developed really quickly if something is found to work well. So the treatment options cover so many different levels of clinical testing, and there's lots of different aspects of it that make it complicated and really hard to know which is going to come first.
I see. Fantastic. And you spoke about the international centres, and you were all talking together so that you're all collecting very similar data. So whilst there may be 50 people from the Stanford study, 45 from the UK study, and what have you, actually that could end up being several hundred people ultimately across the world in the next 4 or 5 years.
Yeah, the international collaboration has been really impressive. I can't believe how easy it's been. Like from a time zone point of view, people are joining meetings at 4 a.m. midnight in their location. And the discussion has been really easy. You'd think you get so many experts with opinions, and you know, is everyone going to agree? And it's just been such an easy kind of compromise or discussion about which outcome measures. Yeah, the meetings have actually been really quick, really productive, and it's a lovely, yeah, lovely international effort.
That's really promising. That's really fantastic, because it's, you know, with such a rare condition, and again, as we said, so many different genes involved, getting the numbers of people and tracing them over time, or and collecting data from them, is going to be so important. So, well, that's really great. And I remember when we first were discussing this, there were 1 or 2 sites, and seeing your map with people, you know, the Southern Hemisphere wasn't even part of that conversation, I think, at that time. So that's brilliant, because of course you've also got genetic diversity by also not just restricting it to, I suppose, sort of US and sort of UK and Europe. So I think that's wonderful, really great. I don't think we've had any questions that have come through the Q&A. So thank you, Gemma, for talking to us this morning and telling us about the study. And if people are interested in finding out more, do contact MD UK. You can email us at research@musculardystrophy.org. No, musculardystrophyuk.org. Oh my goodness. We'll make sure we put it on the YouTube channel, and it's our research helpline, and there are links to it on our website. So do contact us through that route, and we can put people in touch with the team at Oxford and the other centres, so that we can hopefully get people into the study soon. So that's brilliant. And I'm going to hand over back to Rob now, who's going to lead the discussion for the next part of the session.
Thanks, Kate. That's fantastic. I'm sure we can clean up that email address in the edit. Don't worry. So thanks so much, Gemma, and thanks, Kate. So yeah, it's my pleasure to introduce our sort of next round of panelists, and to move the discussion on into sort of living with Nemaline myopathy. So we're really pleased to be joined by Nicola Grose, who's an adult physiotherapist, and we're based in the Southwest Neuromuscular Operational Delivery Network. This is no particular order, by the way, and then I'll go around to people to ask you to introduce yourselves more thoroughly. Marion, a consultant paediatric physiotherapist. Dr. Anna Sarkozy, a neuromuscular consultant at Gosh. Professor Tracey Willis, a paediatric neurologist at the Robert and Agnes Hunt Hospital. And we'll be joined also shortly by Ginny Butcher, who's an individual living with Nemaline myopathy. I'll ask you all in a second to introduce yourselves in a bit more detail, and then Marion and Nicola are going to cover a few remarks about the importance of physiotherapy. But actually, based on some of the comments that Gemma was saying, before I go to Marion and Nicola, and to give Anna and Tracey a fair warning, that theme of collaboration in research was really interesting coming through. So it'd be great to have a few words after you introduce yourselves about sort of collaboration between services and within services in terms of providing care to people with Nemaline myopathy, given the sort of the multiple areas of care needed. So Marion, would you like to introduce yourself first, just a bit about your background and your role in supporting people with Nemaline myopathy?
Thanks, Rob. Yeah, my name's Marion Main. Until recently, I worked at Great Ormond Street. I was with the neuromuscular team for 35 years, and I have parted company with the health service, but I am still working with UCL. I am still actually busier than I was when I was at work, which is what everybody says when they retire from the health service. I haven't stopped in the last month. And I'm still very involved with a lot of interest groups, with a lot of charities who work with people with neuromuscular disorders. I'm very into equipment, orthotics, the idea of standing as a therapy. And I really believe, as a physiotherapist, as a paediatric physiotherapist, our job is not about now, it's about making the best possible adult. And what's interesting is now in physiotherapy, there is much more collaboration between the adult and paediatric physiotherapists than there were even 10 years ago. And it used to be, you know, you'd say bye-bye and think, well, you know, that's your problem now. But it's not quite like that anymore. We are much more collaborative with the adult physios. We want to make sure that we're leaving the best possible adults for the adult service. So that's the aim, not what we're doing in the next 5 minutes, but what we could be potentially doing for the next 18 years. And I think the other important thing that I've always said in all neuromuscular disorders, that there are treatments on the way, there are treatments being tried, and the best possible condition of the patient, the most functional, the most physically able, will gain the most, because the more you have got, the more the treatment will allow you to progress. If you're very, very limited in your mobility, you're obviously going to gain less from these treatments. So a really important part of physiotherapy in both pediatrics, because the children are growing, but also in adults, is to maintain the maximum function, maximum mobility for when these treatments come.
Brilliant, thanks, Marion. Nicola, it makes sense to turn to you next. And presumably receiving a patient from a physio like Marion from Paediatric Services who's been looking to the future is very helpful for you as an adult physiotherapist.
Oh, absolutely. Thank you, Rob. Yeah, thanks for the invite for joining today. Yes, so hi everyone. My name's Nicola Grose. So yeah, I'm an adult specialist physiotherapist working in the southwest, so based at North Bristol NHS Trust, sort of covering the north part of the southwest region. And I've been with the multidisciplinary team for 13 years now, covering a neuromuscular role. Covering all those neuromuscular conditions with Nemaline, being a small group of people that we see within that. And yes, as Marion's saying, I think.
Well, I did see that. Oh, she's back. I think Nicola, you're back. We lost you very briefly. We can't hear you now, actually.
I hopefully heard a little bit of that.
Oh.
Yeah, so I was saying I just cover, with the multidisciplinary team, that the full adult service. And as Marion was saying, I think, like you say, things have certainly within our service, but I think I've also noticed sort of collaboratively around the UK, so much sort of more sharing of knowledge between the paediatric and the adult specialist teams, which is fantastic. I suppose from the adult perspective, as Marion said, we would continue that physiotherapy program, but very much for adults looking at that sort of functional approach and how has that person's life develops in terms of, living independently, potentially work, relationships, etc. How a physiotherapy program or function would sort of, fit into that lifestyle, which may need that adaptation. And, the main things really are about promoting independence, trying to prevent any sort of future complications, very much trying to support that person to live as well as they can be. Can certainly say a little bit more about Nemaline as we come on to the further questions. Thanks, Rob.
Thanks, Nicola, and thanks so much for joining us. Tracey, can I come to you next to introduce yourself and talk about the service you provide to people with Nemaline?
Yes, so I'm Tracey Willis. I'm a paediatric neurologist and run a neuromuscular service at the Robert Jones and Agnes Hunt Hospital in Oswestry, Shropshire. We're very fortunate in that we actually do both a adult and paediatric clinic as part of an MDT. So the team sees the children through from paediatrics through to adults, which I think really benefits both, I think, us as a team and learning together, with a lot of these rare conditions. I think, we have a lot to learn, both, from the patients themselves, as well as from all the developments that are happening with the world of genetics and treatments. And certainly it benefits, I think, our physiotherapists working very closely, both in paediatrics and adults, but also with the orthotics team and our sort of gait lab, and looking at ways that we can maximize, support for these patients. We also, as an MDT, do joint respiratory and cardiac clinics on our MDT clinic. So this is very important for our Nemaline patients, particularly from the respiratory aspect. And carrying on that through into the adults, again, is very important as our paediatric patients go through transition. So it's great that we can support them through that. So yes, that's me. Thank
you, Tracey. And Anna, over to you.
Good morning. So I work at Thomas Street at the Willis Neuromuscular Center, and we do also have a specialist clinic for patients with Nemaline myopathies. We work very similar to what the colleagues have just mentioned. We try to do an MDT approach together, not just with the physiotherapy colleagues, but also with the other services. So it's very similar to what Tracey just said. So I might maybe just focus on the other things that we do offer as well. So in addition to our regional neuromuscular center, we are also the national reference center for rare neuromuscular condition, in particular congenital myopathies and muscular dystrophies, and in this respect for Nemaline myopathies. So we offer diagnostic service and which includes a clinical, a pathological, and a genetic service to achieve diagnosis for patients with Nemaline myopathy, and this is for patients from everywhere from the UK. This is very important in order to achieve the best diagnosis for all the patients, and this comes back to a little bit what Gemma was saying before about patients who may not have yet maybe a genetic diagnosis. Sometimes it's a bit challenging to achieve a diagnosis because the genetic aspects sometimes are a little bit complex, and a specialist approach is very important. So we are happy to receive referrals from all over the UK to help achieve a diagnosis. And in this aspect, international collaboration is often very important, because sometimes the variant in a patient is either ultra rare, maybe never seen before, or maybe only seen in very few other people around the world. And really reaching out to experts in this ultra rare condition who may help you to interpret finding is really important. So a really MDT approach for diagnosis is key. And also to the last really to say, just also to make sure that the patients who may have an Nemaline myopathy who are undiagnosed remain under very good care, to make sure that all aspects of neuromuscular care, cardiac, respiratory, orthopedic, physiotherapy is not forgotten, and continue to monitor them until a diagnosis is achieved.
Brilliant. Thanks, Anna. We heard everything, but you were slightly quiet. So there's a microphone you could bring close. That might be helpful. But we heard you, but that'd be great. This is probably a good opportunity to publicly acknowledge that sort of Tracey, Anna, and Nicola are all based in centres that have recently been awarded MD UK Centre of Clinical Excellence status. So congratulations. So it's great to have that kind of best practice with us. Tracey, we've heard a bit about sort of physio, and Anna mentioned there the MDT and the importance of that. Would you mind just talking us through a bit about kind of the various components that make up supporting someone with Nemaline myopathy, and how the service coordinates that care across all those disciplines?
Yes, so I was going to say, I mean, like a lot of our other neuromuscular conditions, Nemaline myopathy, is a multi-system disorder. And obviously, sort of as was alluded to earlier, that, this can present in a various number of ways. So it can be quite severe Nemaline myopathy in that congenital early phase of life. And, sort of you have your paediatric onset, and then you can have the much rarer later onset Nemaline myopathy. But obviously, sort of as a supportive and, sort of caring for these patients, we need to look at, sort of all their aspects of care. So that includes sort of the motor development, contractures, their spines, whether or not they need orthoses, and obviously physiotherapy to manage, sort of this, and looking for contractures and trying to minimize those, because ultimately we want to keep these children in as good as condition as we can, as Marion and Nicola said earlier, and sort of maintain them through to adult life, to give them that best possible quality of life. But that's also looking at adaptions as well. So that's bringing into that our specialist nurses and care advisors that can help and advise and, liaise with local occupational therapists with regards to adaptions and tools that these patients may need to help them with their everyday lives. And that's supporting the families as well with being able to care for the children, and particularly older children as they get heavier, with regards to their neuromuscular condition. So making sure that, there are things in the house that make things accessible and user-friendly and easy to care for the children and adults with Nemaline myopathy. But additionally, that's going into schools as well, and colleges, making sure that, these young people have got access to everything they need from an educational point of view. I mean, my specialist nurses very often go into schools and do teaching sessions, both for the staff in school, but also for the children as well in the classes, because sometimes it helps them to understand why their classmate has got a disability and why they need different equipment. So, that's a big part of liaising with, sort of the sort of local schools and colleges. And then also, as they get older and into adulthood, very often our care advisor sort of helps the patients with sort of access to work and that side of things, making sure that they've got the appropriate equipment there. Obviously, as Anna said as well, with our MDT, we have to make sure that we are looking after from a respiratory point of view. If there are any cardiac issues, which rarely you find, but we have to be aware of that, but also feeding aspects. So it's engaging a lot of certainly the local teams and community teams with regards to that, and giving them the information and teaching as well about this condition, because very often they don't have anybody else with Nemaline myopathy on their book. So it's making sure that they understand the condition so that they can provide the best possible support for those patients in the locality where they live, even though they come to the Neuromuscular Centre to be seen, once every sort of 6 months or so in paediatrics. A lot of the time they need that access to those local teams for that support. So certainly liaising heavily with their CCNs, so specialist nurses and community nurse teams, so that, if there's any issues with, for example, their feeding tubes or, ventilation side of things, that they've got that access. But making sure that their local hospitals also know about them, that they've got open access available to them, particularly from a respiratory perspective. And that they have a clear respiratory escalation plan if there are issues when they're unwell. So there's a lot of liaison that goes on, with our sort of specialist nurses to the community nursing team, from our physiotherapists to the local community physios, making sure that they can get everything in place so that we can enable our patients to live a healthy life and do what they want to do.
Thanks, Tracey. That's really helpful. Sorry to ambush you, given that you're on, but we did have a question and answer around that respiratory function point, and kind of wonder if you could just explain how is respiratory function sort of monitored in someone with Nemaline myopathy, and you talked about the escalation plan. That'd be really helpful.
Yeah, so I was going to say that the patients, it depends on their level of requirement. So, obviously a lot of the sort of congenital Nemaline myopathies need ventilating either with a non-invasive ventilation or invasive. So some of them will have tracheostomies. They are generally sort of under the respiratory team. So we have our sort of respiratory team that we work with as a neuromuscular specialist centre. But obviously, whilst they do have their respiratory assessments via the ventilation team with sleep studies. For those that are able and they're older and got less respiratory involvement, they will do spirometry when they come to clinic. So we will monitor it that way, as well as sort of their sleep studies. But we also need to liaise with the ventilation team, with their local respiratory team. So that's making sure that they know and are up to date with their settings of their ventilator, that they are up to speed with if they that they know the escalation plan, because generally we have different settings for the patients when they're unwell compared to when they're well, so that they may have increased pressure and when they need it. Also, the escalation of having antibiotics available early in the course of an illness. So a lot of our patients will have backup antibiotics at home to use should there be a start of a respiratory illness. And again, access to suction machines if needed. Not all of them need it, but vast majority, particularly our younger patients, will have access to suction machines. And then some of them will need cough assist machines. And again, that's very much dependent on their needs, and they will be assessed for that and whether or not that is what is required. But yes, having, I think really good documentation with emergency care plans, liaison with the local hospitals, which is where they're going to be taken in an emergency, and making sure that everybody's got open access to the paediatric wards and there's updated information at those paediatric wards with their plans. So it's not just dependent on the families bringing their escalation plan with them.
Thanks, Tracey. And before I bring in Marion and Nicola to talk specifically about physio, Anna, have you got anything to add in terms of that overall coordination of care across the whole service?
No, I think, I mean, that was very, very detailed and thorough. I think it's also important that sometimes if families feel that perhaps some aspects are not being met, I mean, just to remind the clinician, I mean, it's because often families know really well about the condition that, you know, and their child. So I think it's important that also for the families to familiarize with the standards of care. So I think we are all working to make standards of care available for everybody, and there are standards of care for congenital myopathies that are available. There are family guides, and I think for the families also to know all the aspects of care that should be, you know, consider can help for the full coordination.
Thank you. Your sound's much better. Thank you. Marion, turning to you then, you already started sort of outlining some of the importance of physio and the role of physiotherapy. I was particularly interested in what you said about equipment and orthotics. It'd be great if to kind of a bit more detail about kind of what might help. And before I bring you in, I'll just welcome Ginny Butcher, who's just joined us. And I'll introduce you shortly after you've heard from Marion and Nicola. We're just going to talk a bit about physiotherapy and Nemaline myopathy, but very much welcome to the panel. Thanks, Ginny. Marion, over to you.
Lovely, thank you. I think what I want to say right from the beginning is that these are incredibly rare conditions and they are very, very different. You can't say Nemaline myopathy and expect the kids to look the same. They will look very, very different in their severity and their function. The most important thing, as I think Ginny will agree, is that they are bright kids, they are intelligent kids, they know what's going on. So even if they have communication problems, I think it's important for physiotherapists and the people working around them to understand these are children who want to be part of what's going on. I think that it's really important that parents particularly don't get frustrated because their local physio may never have seen anything like a myopathy, let alone a Nemaline myopathy. These are rare. And there are physiotherapists who could have a 40-year career in pediatrics and never see a Nemaline myopathy. So it is frustrating for parents when the local physios don't know. And it's important then that the neuromuscular physios share as much as possible with those teams about the best management. But ultimately, it's all about good assessment. It's seeing how the child is progressing over time. If you expect contractions, don't wait for them to happen. Do positioning, do splinting, do active stretches. We're very keen on active stretches. In other words, if the kid's playing on their phone or their iPad while you're doing the stretching, then parent or carer or even physio is getting a lot of exercise and the child's getting no benefit at all. So we like to make physio active. We like to make it fun. We like to make it part of everyday life because then it's not a burden or a chore. You've got to do your exercises now. You've got to do your physio now. The other thing is that we always say is every time you do something for a child that they could do themselves, even if it's push their wheelchair 10 meters, if you do it for them, you are taking away an opportunity to exercise. So think about all these things the kids could be doing that you're doing for them is exercise. It's not about up, down, and boring and repetitive that never gets done. When it comes to orthotics, again, it's difficult because you will get local orthotists who have never ever seen a child with a myopathy or not that particular type of myopathy. We have a young man, I saw a young man at Great Ormond Street who had splints made at the time he was living abroad. He came to the UK and the local orthotist said, "Oh, we can't make those." Yes, you can. You know, just because you've never seen this sort of myopathy before, it's not rocket science. It's a bog standard splint with a big build-up. It's not something different. And we do have quite a lot of necessity to actually discuss with orthotists as well what can and should be done. And a lot of splints are not fit for purpose because there is no understanding of the conditions, and it does require a lot of support for parents and orthotists as well. I think it's what's important and what really, really gets me, and this is for adults too, is a patient or child to be told you will get used to it. in terms of orthotics. You don't get used to it. If it's rubbing or uncomfortable or restricting your breathing or your eating, you are not going to get used to it. There is something wrong with the orthosis, not the child or the adult. And that's really important. I really do not like this concept of you will get used to it in anything. It's not fair. I really don't believe in pain. That's not necessary. This no pain, no gain is not a pediatric physio concept. It might be sports physio. It's probably not even sports physio these days. Pain is telling you something's wrong. And that is something that, again, is a big area. If it's pressure sores, if it's joint pain, whatever, we need to be looking at the best possible way to get around it. In terms of spinal jackets, there is a lot of controversy at the moment because a lot of local teams are now pushing this sort of softer style orthoses, the more elastics, the straps, the lycra. And in some cases, for some of the milder conditions, they will work. But if you've got a scoliosis or spinal asymmetry that really needs some support, you're going to have to accept a semi-rigid or rigid spinal jacket. It's not going to be held by anything lightweight. They're not brilliant. They're not comfortable. They're not what everybody wants. And for the rare day like we have today, when it's hot, you are not going to want to wear something as sweaty and disgusting as plastic or even lycra, for that matter. So they're not comfortable. And most importantly, again, this is an MDT issue. If you are wearing a spinal orthosis, whatever sort, and it interferes with your function, interferes with your ability to move about in the wheelchair, or interferes because you can no longer have the arm power to lift your arms higher, because when you're sort of scrunched up, your hands can be closer to your mouth than what you need. But when you're taller, held by a jacket, sometimes your arms just don't function in that range of movement. Then this all needs to be considered. So if you're going to use it functionally, then the things around you need to be modified. So there's a lot of things you need to think of just with orthotics, just with jackets. It's complex. And I think people have to appreciate that every child's individual, every family's individual. We have families with more than one diagnosis. We have families with more than one sibling. We have single parent families. So it's not just about what we do as physios, what we do as anything in the MDT. It's treating families. And I really do feel that as a pediatric physio, we need to treat families, not just children.
Thanks, Marion. That's a great sort of ending point. I think we at MD UK we talk about there being over 110,000 people with more than 60 muscle wasting weak conditions, but actually the number of people who require help and support and information is far beyond that in terms of families and the community around them as well. Absolutely agree. Nicola, before I bring in Ginny, would you like to kind of pick up the story of physio from an adult perspective then? And does the equipment just get bigger as people get older, or actually will people require different types of equipment as the condition progresses and as they get older as well?
Yeah, thank you, Rob, and thanks, Marion, for giving such a good overview there. Yeah, I suppose some of the main things to say really from the adult side is picking up on what Tracey was saying. I think there's a significant amount of liaison with anybody else, really, so other professionals, local professionals that an adult with Nemaline may be liaising with. So obviously, as we were saying, it's such a rare condition that people need a lot of that support. So I find myself doing that hugely with those local professionals, particularly occupational therapists, who may be needing to look at different equipment or a different setup for somebody, depending on where they're living. That can evolve and change, and that liaison is absolutely needed because they will not necessarily have that experience or those skills. So it's often, really good to sort of do that joint working to make sure that it's absolutely right for that person. That's a key part of it. And absolutely, as Marion has said, with the orthotic side, that can be quite tricky. It needs a lot of liaison again, trying to pull sort of skills together to really try and get the best outcome for the patient, for the person. And I think sometimes as things change, as an adult gets older, it's still obviously important to be looking at that and trying to prevent complications, but it may be depending on somebody's lifestyle and what they're doing in terms of work and life, that actually trying to think a little bit more around how practical that is for the person, and does there need to be some flexibility around that. I think probably the other experience I've had is, as Marion has said, you know, within the service we have families who are affected. I mean, I can think of one family where 3 generations are affected, with obviously a very different presentation. So, for example, grandmother very mildly affected, and you know, a younger adult much more severely affected. So obviously that's needed to sort of, each individual needs a very tailored and specific approach, and we would try our best to obviously try and incorporate activity as much as we can. It may be that people, depending on their level of weakness, are at a point where their everyday activity, they're just about on that level of managing with their muscles. But even if there's small ways of trying to incorporate other activity into their day, you know, we would look to approach that, find suggestions, find practical solutions, that may or may be with equipment. And then of course there may be an aspect where somebody may need a little bit more physical help. It might be a little bit more around stretches and passive activity, depending on the person's need, or looking at change of positions and things. One of the things I have had experience with Nemaline is, because, as the rest of the panel have been saying, you can have the severity of the respiratory involvement. It may be that when people are trying to be active, actually their work of breathing is quite significant, so they may be quite breathless and may need to prop up with their arms to try and support themselves. So obviously, if that is the case, as things progress, it will be really looking at what is possible, what positions are good, what can be worked around that, because obviously that can be very difficult for somebody. So it may be very much tailoring the physio appointment, session at that time. As Marion said, you know, posture is obviously very important. You know, it might be, as time goes on, thinking a bit about, you know, 24-hour posture, wheelchair, and liaison with wheelchair services, just trying to make sure that somebody can be, the minimising complications, but also enabling that person to live. As Marion said, obviously it can be very difficult if you're too rigidly held to be able to use your arms effectively. So there often has to be some compromise there between posture and function, and that can be sort of obviously an ongoing conversation with the person involved.
Brilliant. Thanks, Nicola, and thanks again, Marion. So, Ginny, it's great to welcome you to the panel. We've heard a lot about Nemaline myopathy, but it'd be great to hear the perspective of someone living with the condition. So I wondered if you could just want to introduce yourself, and then I was very interested in your diagnosis journey as well, in particular, about how it took you, how you got to the point of having an accurate diagnosis of Nemaline myopathy. So yeah, over to you, and then I've got a few questions about coordination and management of your care. Over to you.
Okay, hi everyone. I'm Jimmy. I live in Devon, and yes, I have Nemaline myopathy, which is why I'm here. My diagnosis journey. So I think I was born and got diagnosed with a general sort of muscular dystrophy situation quite early on, after a year. Because my parents saw that I wasn't hitting developmental milestones at the right times and things weren't quite right. So I think I got quite an early diagnosis, but my specific type of muscular dystrophy wasn't identified until I was about 14 or 15, after genetic testing had been allowed to occur for many years. I had biopsies as a child, and I think genetic testing was going on in the background for a long time. So, yeah, I got a letter in the post in my teenage years that said what type I had, and I was like, oh, okay, interesting. I mean, it doesn't really matter to me, I guess, like what type I have, or I'm no expert on the science behind myopathy, but it's interesting, and I think it's good to know, because I can then talk to my specialists about things like, what's the chances of my sister, who is non-disabled, having children who might have muscular dystrophy, or what's the sort of my prognosis, things like that. That question's very hard to answer, I believe. But yeah, so that's kind of my diagnosis journey. I don't think saying Nemaline Myopathy to anyone apart from perhaps the people in this room means much. So when I go to any other specialist, doctor, they say, "Oh, what type?" I'm like, "Do you really care? Like, I can spell it out for you and you can write it down and go away and Google it if you want, but like, let's just all not pretend that you're gonna know what Nemaline Myopathy means." So yeah, it's kind of like by the by, but yeah, just a bit about how it presents for me. Definitely respiratory issues are a massive part of my life. So when I was younger, I had a very severe scoliosis and it got worse and worse, and it was quite severe. And I began using a wheelchair around the age of 5, sort of walking, wobbling around, perhaps, not the right terminology, but you get what I mean. And began using the wheelchair, electric wheelchair, more and more. And at a similar time, I also had non-invasive ventilation, so sort of like a face mask type ventilation. Again, that gradually I had to use more and more, so not just at night time, but then sometimes during the day at school for an hour, and then gradually, by the time I was about 10, maybe 11, I was using the ventilator pretty much all the time. And I also had a severe scoliosis, which was essentially crushing my lungs. That's what I believe was happening. And my muscles around my lungs, intercostal muscles, also just mean that I am really unable to inhale and exhale independently. So it was all working to mean that I could not breathe by myself. So when I was 11, I had the spinal rods operation and I had a tracheostomy put in at the same time. So it was a bit of a double whammy, 2 for 1. And ever since, I've had the tracheostomy ventilated 24/7, and I've been in a full-time electric wheelchair user. So the scoliosis is still present. I think it will always be present, but it's much less severe than when I was a youth, if you will, and we'll see how it goes, I suppose. Tracheostomy will be present forever, and I can't breathe independently at all, really. So that's kind of where I'm at. Because of all of those factors, I do have personal assistants that provide my care 2 to 1. I think it's 2 to 1 mainly because of the tracheostomy, like sort of the risk it poses and the care that it requires means that 2 people is the safest option. So that's kind of me in a medical sense. There's a lot more to me in a non-medical sense, but yeah, there you go.
I was just about to move on to the non-medical sense, because we'll come back in a minute to coordination of the medical care. But actually, I was really earlier before you joined us. We discussed a bit about how services liaise with schools and also support people with sort of adjustments in work. And you're a practicing solicitor, so the amount of work you had to put in at school and through further studies. Be interested to hear just about how did you manage the condition and what adjustments did you have to coordinate to be able to get to the point of becoming a solicitor now and now in the workplace as well. I'd be fascinated to hear more about that.
Yeah. Well, managing the condition when you're a teenager is a nightmare because you're a teenager and you do not why. Okay, so speaking personally, no, why am I going to stop every 2 hours and do a nebulizer? What are you on about? Absolutely not. Oh, like, why am I going to do physio on the weekends or things like that? No, it's very tricky, and I found it very tricky. Growing up with it, I think personally, I reached a certain age. I don't know, maybe when I went to university, 19, 20, when that changed, and as life kind of gets put into perspective, or maybe you become a bit more mature, and I just didn't care so much about doing X, Y, and Z, or just realised that this was the hand I got dealt and I've got to play our cards right. So, but growing up as a teenager, I think very tricky, hard to make friends and keep friends when you're, I suppose it's the same for any obviously physically disabled person, not just someone with Nemaline Myopathy, but quite hard to keep and make friends because you've got carers with you, you've got medical situations going on, you're in and out of school for operations or medical appointments. So it's a tricky one. I think that, you mentioned like doing school and going to university and getting a job. I guess the largest sort of adjustment or thing that I've had to contend with is for having personal assistants with me at all times. So with my job, I'm a lawyer, but the adjustment is that my carers are always going to be with me. So you just have to think about stuff like confidentiality issues with clients I'm working with, or logistical issues like space in the courtroom because I'm working commercial litigation, so we're in and out of court. I guess that was the biggest thing to contend with. And even just handling the care package. So I hire my own personal assistants via direct payments through a personal health budget through continuing healthcare. That's a lot of information there, but that process of getting a personal health budget set up when I turned 18 was extremely difficult. It took a lot of time and energy from both me and my parents. My parents are very good at doing that type of admin, etc. So that was great help. But doing that as I was turning 18, trying to do my O levels was very hard. It took a lot of just mental energy and time and going to meetings with different bodies and people, and I don't know, it just took a lot of admin and thinking and planning. And it took about 2 years, that whole process, to get personal health budget set up for me to go to university and start my sort of adult life. And now that I manage my personal health budget myself, I manage employing my PAs myself, I think that's, if I had to say, like, that's the most sort of tricky thing about living with this condition. I would literally say it's not the tracheostomy, it's not the wheelchair, it's not the body being a bit hopeless, it's the care. Yeah, having to rely on care, having to manage care, having to realise that you're going to live the next however many years in that care situation, and the fact that society, like our systems with getting healthcare in the home are not accessible. They're really inaccessible and they're really hard to navigate, and that's really difficult to think that I'm going to have to navigate them for the next however many years.
Have there been any particular sources of sort of information or support that have helped you and your family navigate those systems, or did you feel you had to kind of learn them yourself as you went along?
Definitely a lot of learning myself, especially with kind of the personal health budget thing and stuff like that. A classic of that is that the NHS will provide you with a budget if you are so successful to get one, and they will specify how you can use it, but they will not give you guidance, and they will not teach you how to be an employer, and they will not help you hire or fire. But if you get it wrong, or if you misuse the funds, or if you don't comply with personal health budget terms, etc., or even if you just have an employment issue like a tribunal, you get so far as a tribunal or a complaint, etc., then it's on your head, it's on your shoulders. So no, I didn't personally get any support from the providers myself. I think my biggest source of support, which has probably been mentioned already, I don't know, but is other disabled people, really, other people who have maybe muscular dystrophy. I know a couple, but I don't know that many, and especially not with Nemaline Myopathy, which is what we're talking about today. But generally, other disabled people who have done this before, they've been around the block, they're older than me, they've lived with this. There are many a Facebook group for that type of thing. I joined Twitter just before the pandemic and really made some good disabled friends. We meet up once a year in London. We try to, and yeah, finding that community who have literally just done it before, or they know their stuff. When they say do this, don't do that, I'm like, okay, I will listen to you because you are an expert. So yeah, I'd say I'm a disabled people.
Thanks to you. That's fascinating, and yeah, very echoes very much with the stories we hear when people come to access the MDUK peer support service, just trying to speak to somebody who's been through something before that they're facing. And it was fascinating hearing earlier from the health professionals about that sort of collaboration and knowledge sharing. And that definitely, I was gonna move on to whether that happened, whether that's something you'd access. So clearly you have in terms of the peer support. I think that point around the admin and the management of care and the pressure that brings on. It was fascinating doing some work last year as we refreshed our brand and asked people affected by muscle wasted conditions kind of what were the big themes they wanted us to talk more about. And it was just, I think the line that came through very strongly from several people was, it's just exhausting, like let alone physically, mentally, it's just exhausting to manage a condition like this where you have to have so many sort of components in place to help you, not just the healthcare, as you've said.
I think it is, and unfortunately, I don't think that any of the systems for disabled people are built for someone who has a life or has a job, and I think that's really difficult. For example, someone mentioned, I think Nicola maybe mentioned wheelchair services a minute ago, or Marion mentioned wheelchair services. I mean, for example, I'm a full-time wheelchair user. Anytime you want to see wheelchair services, you have an issue with your wheelchair. So actually, this week I asked them to come out. They came out on Wednesday. Just as a small example, wheelchair services can never give you a time slot when they're going to come. So you're going to be home the whole day. And it's just like, is that viable? Because I work full time, right? So like, how do you expect me to be at home the whole day for a half-hour wheelchair appointment? Why can't you just factor in the fact that some of your patients, clients are not going to be able to do that? Or, yeah, all the medical appointments you have to go to a hospital, clinics that only happen on a certain day per year. What if I've got something big on that day? Like, I just, yeah, there's a lot that goes into it. People ringing you during the working hours and they don't understand, but oh gosh, like, you can't do it. No, I genuinely can't do it. I'm sorry, I'm not trying to be difficult. I mean, sometimes services act like you're sort of refusing care or refusing assistance. I'm not. I just need systems to be a bit more flexible for like someone who isn't a child and who doesn't have like someone else doing it all on their behalf because I'm able to do it myself. I should do it myself. I want to do it myself. Then I just need systems to work around me a little bit. That would be nice, but it doesn't work that way. It all seems to be built for either like young people or who have parents, etc., or people who are not able to look after themselves, so therefore they are looked after by somebody else who does all of this on their behalf, an advocate or a family member or whatever. Yeah.
Thanks, Ginny. That's fantastic. I'm going to turn to I think Tracey and Anna next, just to kind of cover something. Ginny, we talked a bit. Gemma talked in her session a bit about the discomfort of biopsies and the kind of that journey of having muscle biopsies, and you talked about your diagnosis sort of process, and it came through in a recent community survey of ours about people having different diagnoses before they got to the right one and how long that took. I won't reveal. Ginny's a young adult. I won't reveal her age. But is that Tracey and Anna? Is that sort of genetic testing? Is that coming sooner now in terms of someone when they present with symptoms? Is how might a diagnosis journey be different now than it might have been a few years ago for Ginny?
Okay, maybe I can make a quick comment. Yeah, so it's definitely coming quicker. I think there has been major advances in genetic technology. The complexity with Nemaline myopathy is that we have many genes, and some of the genes are incredibly big. So it's not just a question of analyzing them quicker, but that really it's the complexity of some of these genes. In the past, until maybe 10, 15 years ago, we were really going gene by gene, and the biopsy was very important, because if the biopsy showed Nemaline bodies, rods, then, or changes that in keeping with Nemaline myopathy, we would have sequenced each gene that were known to associate with Nemaline myopathy one by one. And in about 2015, 14, 15, we started to do next generation sequencing, which is much faster. And nowadays, because it's faster, when we suspect that somebody may have a congenital myopathy, possibly an Nemaline myopathy, we would do genetic testing for all the genes that are associated with this condition. Caveat of this is that, again, some of these genes are really complex, and sometimes you have a result that is not negative or positive, is in between. So we still have quite a number of situations where the answer is unclear or negative. And then you might need to do a biopsy still today to clarify maybe the role of that change, or understand if it's negative, why it is negative. And if you find changes that are suggestive of an Nemaline myopathy, then you might do more investigation, perhaps look for genes that are not officially associated with this condition yet, or look for parts of the genes that might have been missed by the standard technologies. We are good, we are better than before, but there's still quite a lot of work where you need a little bit more specialist technology and input.
Thank you, Anna. Tracey, have you anything to add to that?
No, I don't think so. I mean, I think it's just important when I'm seeing our adult patients, some of them are still undiagnosed, and it's very important to go back and relook at these diagnoses. Now, with more genetic testing available and whole genome sequencing, we can actually now get diagnoses on some of our adults that have been labeled as myopathy query cause, you know, and they'd had a biopsy years and years ago. We sometimes try and look at it and review it, but sometimes it's not very helpful. And as Anna said, sometimes the biopsy is not confirmatory, particularly, you know, sort of with the Nemaline myopathies. You know, we now know there is quite a widespread of changes that you see on a biopsy. So I think that's the important thing from the adult, you know, sort of a clinical side of things, is always questioning and re-looking at the diagnoses when patients haven't got a secure diagnosis, particularly now with what Gemma said about some of the treatments now coming on board, that actually it's important to have that secure and genetic diagnoses to think about potential treatment options.
Thanks, Tracey. I've got a couple of further questions that I think are more for Tracey and Anna. So just a final plug for people to use the Q&A function before then, because I'll go through those questions, then I'll invite the panel to say a few sort of final words. It was interesting hearing from Gemma actually about that those potential treatments and that kind of what might be on the horizon. In terms of how you incorporate that into a clinical service and service provision, how far ahead do you start planning for a potential new treatment, or actually do you just have to wait until it has got to the end of the process with NICE, because you just never know whether it's going to be rolled out or not?
I don't know if you want to go first, but I guess it's very depends on what the drug is. I mean, and clearly there are some drugs that are available through clinical trials, and the patients may highlight their interest for research. And if specific centers in the UK, there are clinical research facilities where patients may take part in a clinical trial. Clearly, we don't know until a drug is under development if the drug is working or not. And then when there is evidence that these drugs may have, benefited, may work, then there is all the process through NICE. And there are different ways for these drugs to come into the NHS and the healthcare. You know, sometimes some drugs may have an early phase when you continue some investigation in the real world, like through managed access agreement and so on. But what we usually do in clinic is we discuss with families when they come to clinic news and new developments, and keep our patients informed. And the UK does a fantastic job as well in this, to, put the information out there for families. And if patients read anything, they can always contact us. We always encourage them to reach out to their doctors if they see something that they're interested, so that they can get the right information from the source at the UK and the clinician, really.
Thank you. Anything to add, Tracey?
No, I think that's the same for us. It's, it's making sure that patients and families have got that correct information, and and trying to manage expectations as well, with all the new developments that are happening.
Brilliant, thank you. And Gemma, in terms of that sort of how we often hear with very rare conditions like Nemaline myopathy that there's such a small population to do research on, that actually those things like managed access agreements where people can receive a treatment whilst still measuring where still have it undergoing sort of measuring of effectiveness, etc., are increasingly important. So presumably from your point of view, seeing research benefiting patients in real time is quite positive as well, where that's possible.
Yeah, I guess there's a trying to not see it as a barrier and combining research with clinical care on an individual patient basis is hopefully, yeah, the future of how things will go.
Brilliant, thank you. I'm going to start going around the panel to give them final words, and I'll go to Ginny last as our real expert on Nemaline myopathy. But so yeah, a final call for anyone to use the Q&A function, because we can sneak in a couple of questions if any more come through. So I'll turn to the physios first, not lump you together. But yeah, Marion and Nicola, any sort of final observations or thoughts on kind of what we've heard today and kind of management of Nemaline myopathy?
I just want to echo what Ginny said. I worked for the health service for 46 years. And in all those 46 years, my biggest bugbear, the one service that continually goes backwards and not forwards, is the wheelchair service. I worked many, many years ago with MD UK to get wheelchair services together, and about 2 turned up. They don't care, they're not interested. They've got a lot worse since privatisation. And I think it's disgusting that when your wheelchair is not an extra, it is an essential. It is your legs, your life, your work, everything that you do in a day. I think there really needs to be something done. Having said that, if Ginny, as a lawyer, wants to contact me, she's very welcome, because we are doing a campaign to try, and nobody's going to change wheelchair services unless they take them away from privatisation. But we're certainly hoping to be able to change the stupidity of their rules and regulations and the way they treat people like lumps of meat instead of people who really need their wheelchair forever. I think generally everybody else is moving forward. And what's lovely is to hear Gemma with treatments moving forward, because I think in the rarer of rare disorders, people do feel left out when you look at what's happening with Duchenne and SMA and the more common disorders. I think it's just nice for people with these much rarer conditions to feel that they're being looked after too.
Thanks, Marion. Nicola?
Yeah, thanks, Rob. I think, yeah, just to echo what Ginny and Marion were saying, I mean, we've all experienced sort of those difficulties with services, and thanks, Ginny, for being so honest about your experiences, really. And I think you're right, it is very tricky with wheelchair services. Locally, we happen to have a meeting coming up with them actually recently, coming up soon. So that's really great feedback to sort of take to them, really. And I think it's just really for all of us to sort of keep on advocating, isn't it, on behalf of those people that we serve in the services. So, and I think I was reflecting on what you're saying, Ginny, generally about navigating things in the adult world, and particularly sort of the care side of things. And whilst our focus might be more on the clinical side, I do always hope that within the MDT, that obviously that's the least we can do, is try and sort of advocate and support you in any way that we can. So we definitely try to do that in a very holistic way as best we can. But I appreciate there are still gaps and difficulties, aren't there? So, raising awareness like events like this is really, really useful. Thanks, Rob.
Thanks, Nicola. I think I should reflect that, yeah, the experience supporting patients and sort of families through the wheelchair services process, and also through challenges with wheelchair service, was a huge theme that came through in our Care Advisor conference. We bring together care advisors from across the UK, so once a year, for networking and training, and I think it was on the agenda, but then it spilled out into much wider discussions around the frustrations with wheelchair services and the need to see real change there. Tracey? Actually, I'll go to Anna first, because someone's coming behind Tracey. It's a bit unfair to make Tracey. Anna.
Well, it's just to highlight again the importance of trying to achieve a diagnosis, but also in the meantime to focus on this MDT approach for clinical care. And so the two things should really go in parallel. They're both important. And just to say that if the patients feel that some aspects of the care, of the diagnostic aspect, is lacking, or so they should really contact their clinician, make sure that every aspect are taken care for. And we're here really to help.
Brilliant. Thanks, Anna. Tracey?
Yes, and I would echo that. I mean, I think Anna alluded to it before, that, sort of giving families and patients, particularly our adult patients, that, you know, sort of that information and that power to be able to take forward so that they can advocate for themselves, to make sure that they are receiving the right treatment, you know, sort of because care can be disparate around the country, as we know, and it's making sure that, you know, they know and have access to the standards of care, and that they can, you know, question their you know, sort of medical team to make sure that they're getting the best for themselves, but also use their MDT. As Ginny said, I think, you know, one of the biggest issues is accessing care, managing your care, you know, sort of, and, you know, sort of the whole nightmare of dealing with personal payments and, you know, sort of PIP and, you know, sort of, getting, you know, sort of the number of hours of care that you need to make sure that you can live independently and, you know, be able to work and function. So I think definitely, you know, make sure that the care advisors are up to speed with that and helping you and advocating for you to make sure that you can, you know, live the best quality life that you can.
Thanks, Tracey. Gemma?
Really just a thank you from me to the panel and Ginny and everyone. As a paediatric doctor, particularly hearing a bit more about the adult aspects of life with Nemaline myopathy has been really useful. And, you know, if anyone's interested in the natural history study, please do contact us via MD UK. That'd be great. Thank you.
Yeah, just to reiterate that, yeah, very much MDUK's role is often very much a convening role. So if anyone wants any further information about that, do come to MDUK and we can pass those details on. Ginny, final word to you. Any sort of final thoughts?
I think what everyone said is great. I would just say again, sort of building on what I said previously, that it would be really nice, and nice is a pathetic word, it'd be really beneficial if more medical professionals, more services could put the disabled adult, when they're dealing with disabled adults, at centre of what they're doing. Lots of people say we're person-centred or we're patient-centred, and that doesn't reflect in the practices that they practice. So I would really ask for that to happen, and I don't know if anyone's sort of all up in the social model of disability, but I really do try and embody the social model of disability, and I think that, you know, where society causes like a problem with accessibility or provision, then that's something for society to fix, and not for the disabled person to be sort of blamed or scrutinised or have a burden put on their shoulders. So I would really, you know, ask people to just see how they can make lives just easier for those disabled people, really, rather than asking them to do X, Y, and Z, put in more labour, put in more work, hours, emotional labour, whatever, seeing how we can relieve that from people, including not just adults, of course, but I speak from an adult perspective, but that would apply to carers and parents too. Whatever we can do to make those burdens a bit lighter is really positive, rather than always saying you need to do X, Y, and Z, or you need to contact X, Y, and Z, you need to research X, Y, and Z. It's just yeah, it gets a bit much. So if we can reduce that, that'd be great. That's what I would say.
Brilliant. Thanks, Ginny. So that brings us to a close this morning. A huge thanks to Gemma, Marion, Tracey, Nicola, Ginny, Anna, and also Kate for chairing the first session on research. It's been great to have you all with us. The recording of the session will be available online shortly. You can see the details there for our helpline and our info service, and also the email address to if you have specific questions about research. Do please keep in touch with Muscular Dystrophy UK. There's a further series of these condition-specific seminars, and then there's some physical events later in the year as well. So keep an eye on the website for details about that. But a huge thanks to the panel, a huge thanks to our sponsors, PTC, whose support is very welcome and who were independent of the agenda or the content of the session. So I will let you enjoy the rest of the weather today, because I think inevitably it turns on Saturday morning. So great timing. But thank you, everybody. Have a good rest of the day, and thank you very much for joining us. Take care. Bye-bye.
Goodbye.
Thanks all.